Hi everyone and welcome to today's webinar called Reproductive Health Innovations. So it's the second webinar in a series where we present the 4 projects that were awarded a grant from the Reproductive Health Supplies Innovation Fund in a special youth-focused round that we launched with support from the David and Lucile Packard Foundation. So today we are joined by VillageReach and CEDES and Fundación Hesquet. So through a pharmacy assistant training program, VillageReach tackled key barriers to youth access to reproductive health supplies in Malawi. And in Argentina, I'm going to use the abbreviation. So in Argentina, CEDES and Fundación Hesquet designed and launched an open source platform called Donde, to help young people locate reproductive health and contraceptive distribution outlets, as well as safe and legal abortion. So they will present today on the outcomes and the findings of their projects. So the first presentation is from VillageReach, and after each presentation, we will have a brief Q&A session to allow for targeted questions to the presenters. You can pose a question by raising your hand or by sending in a question through the chat, which I will then relay to the presenters. As you all know, as always, all presentations are recorded. All webinars are recorded and will be made available on our website. If you have any questions after the webinar, always feel free to send them to the RHSC Secretariat, and we will be very glad to relay your questions. So the first presentation is by VillageReach on their project in Malawi, and we are joined by Matthew Ziba from VillageReach Malawi and Aaron Larson Cooper, who we thank very much from waking up this early to present on a webinar. So Matthew and Aaron, the floor is yours.
Thanks, David. Matthew, are you still there?
Yes. Hello, thank you, everybody. As David has already said, I'm Matthew Ziva from Malawi. I'm presenting from Malawi, where this project was actually implemented. Basically, it was coined as expanding youth access to reproductive health through innovations. Malawi as a country didn't have any formal trained personnel working at the last mile, and we found this to be very innovative because the few personnel that we trained are actually helping a number of facilities to address the obvious challenges at the last mile. Some of the, my presentation is going to take this outline. We're going to talk about the challenges and the theory of change, objectives, the timelines of the activities for this project, the summary of outcome, and also what we did on youth-friendly health services. And we're going to share also the lessons learned and the recommendations based on the findings, but also the experiences that we have as a result of implementing this innovation. Next slide, please. Yeah, there are several challenges for youth trying to access reproductive health commodities in Malawi. Mostly it's because there are no properly trained personnel, especially at the last mile. And this is a very obvious challenge for most of third world countries, especially specifically to supply chain. As a result, because you don't have specifically trained personnel, data that is reported on logistics management information system is very unreliable, and because of poor data, replenishments are either low or they are over, so it leads to stockouts and the overstocks. leading to disruption of services, but also limiting access to services, especially to the youth, in terms of reproductive health commodities. There's a lot of wastage that is coming either because of overstock or poor storage practices. So there's a lot of loss because commodities shelf life is reduced. And there are a lot of barriers to provision of youth-friendly services because there's actually stigma. People don't know exactly what they're supposed to do. They talk against the youth when they want to access these services, or the youth are not able to access variable information to make informed decision about reproductive health services that will actually assist their life. Next slide. Next slide, please. Yeah. To begin with, let me give you a small background about VillageReach. VillageReach main purpose is actually, our mission is actually to save life through improving access to health, especially for the most underprivileged, especially for those that are at the last mile. You know, in major cities, towns, and districts, there are qualified personnel, services are easy to get, but at the last mile, there's a lot of neglecting. People don't have full access to information and the services. So VillageReach is actually trying to address that, to bring the gap, to bridge the gap between the services that are provided in the major cities and those that are underprivileged at the last mile. Currently, we have 170 employees working in sub-Saharan Africa. I think you can make reference to where we are actually in Africa and Pakistan. I think that's the map presented. The major interventions that we are in are supply chain and logistics. There are a wide range of interventions that we are actually bringing to the community. Most of them are very innovative ideas. And also we are into human resource for health, that's health workforce development, but also digital health and data analytics, that's visual access network. Next slide, please. Our theory of change was basically designed to address, to provide a systematic approach to implementing this innovation to address the challenges that we have actually highlighted before. Basically, as I also already mentioned, that the root causes are reproductive health commodities are frequently out of stock or overstock, and youth access to these is hindered by stigma and also lack of information. So the biggest problem that we identified was that youth do not have access to full range of reproductive health commodities. These root causes are bringing this problem. So our intended outputs were, first of all, to have the pharmacy assistant trained in the mentorship program, and also to have the healthcare staff mentored in improving management of reproductive health commodities and increasing accuracy of supply chain data. And also to, as regards to youth-friendly pharmacy services, we created standards that can be incorporated into the national training system, but also to inform national protocols on youth-friendly services. The outcomes of these outputs were, one, we improved access, improved health, improved reproductive health commodity management, because these people received the training, and also improved the data accuracy by the mentees, but also ultimately to improve availability of reproductive health commodities. And as regards to youth-friendly pharmacy services, because these people will have the training and the knowledge, then they are going to provide an improvement and bring a change and make all the facilities to become youth-friendly, especially as regards to pharmacy. So all these interventions are ending up to have an impact in terms of increased access of youth to reproductive health commodities and services. So, Pharmacy Assistant Mentorship Program, the major objective was first of all to address challenges of staff shortage in human resource for health, addressing issues of avoidable stockouts, especially for reproductive health commodities, minimize wastage. I'm on the next slide. Sorry. To minimize wastage that are coming because of poor stock management, and provide training to pharmacy assistants on youth-friendly pharmacy services, which is a component which is not part of their pre-service training. And based on whatever we are going to learn from implementing the project, we were to make recommendation to the Ministry of Health, especially the Reproductive Health Reproductive Health Department, on the youth-friendly pharmacy services. Next slide. So this project, it started in 2016, where we actually gathered a number of people from both a number of stakeholders, mainly the Ministry of Health and other players in the reproductive health arena, to develop a document that was to be used by the mentorship document, actually, that will be used by the mentors and also the mentees to implement the mentorship program. This document was actually developed in October. We reviewed it in November, and it was ready in January, where we, on the 26th January, just to be specific, we brought in pharmacy assistants who are government employee working at the last mile, that's at the health center or health facility level, to give them with the skills on how they can mentor other facilities that do not have a trained pharmacy personnel on how they can manage commodities and also how they can bring up the standards to address the challenges that we highlighted before. So February was a month when the actual mentorship started, and it was a phased approach. We did little by little because the people they were training didn't have a formal training, and they had to do by the actual mentoring of these facilities was actually slowly, so that these people can capture and they have the knowledge to understand exactly what we meant by youth-friendly pharmacy services. So these were conducted up to July, and in July we decided to have a comprehensive training in youth-friendly services, and we conducted that. And in July, also at the end of July and partly August, we wrote recommendation to the Ministry of Health and also one of the major training institutions to have the recommendations included in the formal pre-service training. Those are the pictures. You can see one of the lecturers training the pharmacy assistant. Then down there you see a mentor mentoring a mentee, and that's a clinician who was actually benefiting from the services that a mentor and the mentee were actually offering to these facilities. So let me explain exactly what we're doing in the pharmacy assistant mentorship program. So the pharmacy assistant mentorship the pharmacy assistants were trained to provide mentorship to health workers at the health center with no trained pharmacy personnel. Because what happens is, because facilities don't have a formally trained pharmacy personnel, they tend to do task shifting. So you find that security guards, hospital attendants or cleaners, they are the ones who are actually undertaking these tasks. So they would go and identify a specific person based on specific basic needs of that facility, and conduct the mentorship to that person. So the very first mentorship that the very first visit that they did to this facility was to conduct a needs assessment and to also set the goals together with the mentee. And they also did a lot of actually support to these people to provide them with information on how they can manage the information so that the reporting on LMIS is accurate. They will also be training them on the ordering and the receiving of commodities, storeroom management, and also some of the basic dispensing environment creation. So those were the major areas that we actually were training them, and also how they can bring in the youth-friendly environment. The next slide shows some of the positive results that we actually received. There was an all-round increase from visit 1 to visit 3 in terms of storeroom management, and also storeroom practices. So from the first visit, the second visit, and the third visit of our M&D data collection showed an improvement, a tremendous improvement. You can see like storeroom organized from like about 30% to it rose to about 90-something%, and all those indicators actually showed that there was a tremendous improvement in terms of the storeroom management. In terms of data accuracy, you'd also see there was overall it was 86% increase from 60% increase. This one we are talking about matching what was actually recorded on the stock cards and what was a physical count on the shelf. So there was a tremendous increase of about 30% in terms of data accuracy. That actually helped to improve the reporting by these facilities. There was a mixed results in terms of percentage of facilities with matching physical count and stock card data, as you might see. I think there was some contributing factor to this because I think some of the mentees that were given initially had also other tasks, and these facilities didn't understand exactly that we needed to continue with the very same mentee. So you will see that overall, you see that there was this, like a slight decline. We increased, but a slight decline in terms of the overall performance in terms of the accuracy. This was specifically beyond the project control, because the people that were actually being trained to work in the pharmacy had also other tasks, so they were actually, we coincided with a cycle of change. So when the data was actually being collected, the last round of data, they had just done a change in staff, so that actually brought a little bit down the indicators. Percentage of facilities that were stocked out on the day of data correction, you will also see that there was a decline overall. Most of the facilities were not actually stocked out, but those that were stocked out at the day of the visit, they were stocked out not because of the management aspect, because of the mentorship program, but because it was a national program, national problem. Nationally, they had not done some distribution because I think there was a death in the reproductive health department, and that actually, because there was no logistician there to do the distribution, I think there were some months where the distribution didn't happen in time. But basically, there was an increase in the average number of stockout days over the period of 90 days. you would see that it's because of the previous slide that actually led to the overall increase in the number of stockout days. But this was mainly beyond the project's control, because commodities are actually controlled centrally and distributed to facilities. And when the facilities don't have this, they end up in stockouts. So the facilities could not even do, they don't even do emergency orders for these project commodities. So next slide. Next slide. Yeah. Yes. So as regards to youth-friendly pharmacy services, there are a number of barriers to youth-friendly pharmacy services, as you might know. That some of them are due to health provider attitude. Some health workers are hesitant to share sexual and reproductive health information with patients who are unmarried. Some health workers adjust their choice of commodity based on age. Infrastructure, you know, it's a big challenge. Most of the services are offered at the very same, I mean, everybody actually gets the same services at the same point. So the very few facilities had youth-specific services areas or private areas to receive counseling and commodities. Most contraceptives are dispensed by nurses or community health workers during family planning days. Information is not there. There is lack of proper information in the community, and even when they are dispensing, these people don't make informed choices because they don't have adequate information about all the methods that are available. Commodities, youth preferred methods are not mainly not available. You will find that most of the methods that are there, they are few and not necessarily youth friendly. Next slide. So based on whatever we actually implemented in this, we made recommendations. One, the first recommendation was that pharmacy personnel should be involved in dispensing reproductive health commodities, as well as provide ongoing counseling for various contraceptive methods. Currently, it's not pharmacy personnel who do the dispensing. It's either a community health worker or somebody else. And these people are not well informed actually about the methods other than the pharmacy, trained pharmacy personnel. Secondly, pharmacy services providers in all delivery points have the knowledge and skill and supportive attitude to effectively provide youth-friendly health services specific to adolescents. Structured physical environment is in a way that allows adolescent patients to seek services, commodities, and supplies privately. But currently, we see that that's not what is happening. So we also made a recommendation to ensure that information, education, and communication materials are relevant to adolescents' needs. And lastly, we also said maintain a high quality data on productive health commodities, specifically those preferred by local youth. So the Reproductive Health Supplies Coalition Fund serves as a catalyst to future work. Since the RHC grant ended, the Pharmacy Assistant Mentorship Program has been scaled up to 5 districts, and it's going to extend to 16 districts because there were a lot of positives that were observed, especially in terms of data management, but also availability of some of the commodities which were coming as a result of the quality report that was being produced. USAID, who are the main donors of the reproductive health commodities, malaria, and TB and HIV, felt that this is a very good initiative, and they saw that there was a need to scale this up to all, to the 16 districts where they're implementing some of the family planning projects. We also anticipate that a component on youth-friendly pharmacy services will be added to the pharmacy assistant curriculum when it comes to pre-service training. Next year, they'll be doing a review of the curriculum so that they have actually given a green light that are going to include these youth-friendly pharmacy services in their curriculum. Similarly, we hope that the youth-friendly pharmacy services recommendations will be adopted into the National Youth-Friendly Guidelines next time the recommendations are formally reviewed. These happen every 3 to 5 years. So the current standards will be due in the coming months, this or next year. So they actually took our recommendation that these are going to be incorporated in the next review. I would like to thank you for your listening and open to questions from the listeners. Thank you.
Yes, thank you, Matthew, for that presentation. I'm sorry if the slides didn't switch as quickly as it should be, but a lot of attendees were having troubles with joining the webinar. So it was a little bit over questions. So I think we have time for 2 questions. So yeah, the floor is open for questions. So if you have a question, raise your hand or post it in the question box. I see one person has raised his hand, but I don't know if that's on accident. So Lucy Wang, do you want to ask a question? I think that was by accident. So does anybody has a question for Matthew? And if not, well, you can always send a question later. We will gladly relay it to Matthew or the people from VillageReach. So thank you again for joining us for this presentation and the lovely project. I think that the results are really great.
Okay.
So next we have Mariana from CEDES and Betiana from Fondation Espoet, who will have joined us and will elaborate on their project called Donde. So Mariana, the floor is yours.
Okay. Okay. So you can see the screen?
Yes, thank you.
Okay. Hi, good morning. Thank you everyone for joining us. It's a pleasure for us to present the results of a project that both institutions, CEDES and Fundación Huésped, located in Buenos Aires in Argentina, performed to try to foster the access of adolescents to sexual and reproductive services and supplies. So the context is that I'm trying to, okay, here. Is that in Argentina, there were reports and local research that said that adolescent fertility particularly was a matter of public health concern. But more from a clinical perspective. More recently, adolescents were part of projects related to HIV, STDs, sexuality, but also to understand why we had second pregnancies among adolescents, even when they delivered at health services, and report said that they received counseling after that. And results from the national survey that was conducted in 2014 provided national and regional data for boys, for girls, teenagers in general, on sexual initiation, knowledge, use, and access to contraceptive. And the population were adolescents between the ages of 14 and over. At the same time, this is a country where innovative and comprehensive sexual and reproductive health regulatory framework is in place. Just to mention, it's legal to marry somebody who is from the same sex. There's a law that allows people to change their names and based on their sexual identity, gender identity. So the question is why, even when we have these very comprehensive and innovative laws, we are kind of far behind in providing services to adolescents and having them accessing those services. So bottom line, most of the indicators that we have when we compare adolescent fertility or rates of infection and even maternal mortality are poor compared to countries that are in the region and do not have those progressive legal frameworks. Just to give a couple of data, the adolescent fertility in Argentina ranks as one of the highest in the region. Compared, for example, to Paraguay, Uruguay, and Chile, those are kind of our neighboring countries. Argentina has almost 70 live births per, 70 newborns every 1,000 births. Adolescent fertility also shows no changes in the last 25 years, despite the decrease that we have seen in the total fertility rate. Also, adolescents give birth to almost 15 of all live births in the country. And this is, of course, mainly on adolescents who are coming from poor or more challenging families than the ones from middle class or upper middle class families. And 7 out of 10 adolescents reported that those pregnancies were unintended. And that figure goes up to a higher unintended rate when you just look at the ones that are younger than that. And even when that is considered a felony, it's abuse and you should report them, the trends and the rates are not going down. But most, as a matter of a higher concern, is that they are not using contraceptives, not before the pregnancy, and a lot of them not after that they gave birth. So some studies report that 90% of adolescents reported using a contraceptive in their first intercourse, but that contraceptive could be a condom, and we know that that is not necessarily a study use. Some of them reported having coitus interruptus, that's trying to pull out before before reaching, the climax. Also, 90% of sexually active adolescents said that they were using pills or barrier methods, but if you can see that prevalence is almost half and half, and when they refer to barrier methods, we are not sure that they are using in a continuous way. And also, only 43% of adolescents, female adolescents, reported that they obtained the contraceptives for free. And this is very important because the Public Health Service in Argentina provides contraceptives free of charge. That means that any adolescent can reach a service and get pills, get an implant, get an IUD, get the injections free of charge. And if you think an adolescent and the capacity they have to pay for services or to pay for the commodity for the actual contraceptive, that is a matter of concern when we only see that 43% of the ones that reported being active and using contraceptives are obtaining them for free. And last but not least, abortion is legally restricted in Argentina. Exceptions are rape and risk to health and life. But in any case, even for those adolescents that are victims of abuse, it's hard to get a legal abortion. And just to give you a figure, 8,600 adolescents were discharged from public hospitals due to complications of abortion. We don't know exactly how what it is in this category, because it could be also legal abortions, but the Ministry of Health does not report them in a separate way. But in any case, that means that these 8,600 adolescents were exposed to some kind of risk and ended in a hospital and being admitted to treat them. At the same time, adolescents have access to internet. A recent survey conducted by UNICEF, where Fundación Huésped also participated, reported that out of the 13 million of adolescents that live in the country, 6 out of 10 use cell phones and 8 out of 10 use internet. So bottom line, they do have access to the web and to information that is there. At the same time, when the study asked about the frequency of internet use, you can see that half of them use internet all the time. And that is the reason why we thought that a web app that could be used without the need of download it could be an excellent resource for them to access information and proper services. So the goals and the objectives of this project were promoting adolescents' access to sexual and reproductive health information and contraceptive access through the development of an application that allows identifying delivery points and gathers crowdsourcing data related to the quality of those services. Our final aim was to strengthen the agency of young people, their capacity to report and participate in the evaluation of services and the type of care that they receive, but also to be able to make sexual and reproductive health decisions and behaviors. So we design and implement a web app for adolescents to access sexual and reproductive health services and also, or particularly contraceptives. Also provide access to geo-reference information on services and contraceptive delivery points, frequently asked questions on contraceptives with emphasis on long-acting reversible contraceptive methods, and also provide a crowdsourcing platform to promote adolescents' agency and foster their accountability for those services. So I will pass on the microphone to Betiana, who is the other co-investigator of this project. So she will talk to you about results and our lessons learned from this project. Thank you.
Thanks, Mariana, and thanks to the coalition for the invitation and the opportunity to share about the work we have been doing. So we have created in 2013 the platform Donde, which means where in Spanish, and it's an open source web app functional from different devices that let the users geolocate different types of health services. It was the result of the work with the team of Open Government from Buenos Aires city government, and on that moment, it only located condom delivery points and HIV testing places. During the following years, we continue working and improving the platform, and in 2016, with the support of the coalition through the Innovation Fund, we've done a qualitative improvement, including new features. We have the possibility to locate contraceptive delivery points and also legal abortion counseling. It is indicated by in the image you can see in the screen, and it means that we have to obtain databases with georeferenced information about those providers and curate the basis to upload to Donde. Next. And Mariana, I need that you put the next slide.
Yeah. There
Okay.
was a delay, sorry.
Okay, it's okay. So a complete new feature was the possibility for the users to access quality services. After the users locate one provider, they can go to a short survey with questions about the service or supplies demanded, the information received, comfortability and privacy, and the next users can see the emoticon assigned as qualification and the comment left by the previous user. So they can use that information to choose among different services. And for us, as administrators and as administrators of the platform, this information led us to identify good practices and also barriers in the access to services. Next. We also did a social media campaign focused on LARCs. Periodically, we do posts on Facebook, Instagram, and Twitter. There are some examples, and for example, one of them says, can you imagine a contraceptive method that you only have to check a few times a year? It does exist. It is the subcutaneous contraceptive implant. And another says, is it hard for you to take the pill every day? There are other options. Hormone contraceptive injections are administered every 3 months. Or, do you want to use a hormone-free contraceptive? The IUD is hormone-free. So we speak in a friendly language, and we use the knowledge we have about what are the main issues related to the different methods and to suggest to use the LARCs methods. And finally, we develop content on sexual and reproductive health and contraceptives for our website. We add a section on our homepage called I Am People that you can see with the person foot in the screen. And when the people clicks there, routes to different sections: sexual and reproductive rights, donde, video games, Q&A, STIs, and contraceptives specifically. On contraceptives section, there is a comparator among contraceptives and information of each one. Next. So, Donde has 4 basic essentials. On the one hand, search and localization, service assessment, advocacy, and collaboration. And collaboration, we think, is a cross-cutting theme because having done the operative is possible because of the work with other social organizations, youth organizations especially, to validate and disseminate it, and also governments and donors. And I'm going to share some results related to each one. Next. Currently, we have on the platform more than 15,000 centers located all over the country, and almost half of them are contraceptive delivery points. The total number of centers located is less than the one presented in July when we did another webinar, because we were working to curate the database and we identify some centers duplicated and we delete those. We have received 132 evaluations through the survey, and it's the double of evaluations since our presentation in July, and most of the evaluations are positive. And we also received 43 suggestions of new places because the users can add sites and we can accept or reject that suggestion. Related to access to the platform, during the last year, we have 21,000 sessions of 15,000 users, and most of them are between 25 to 34 years old. And the main way to access is with mobile devices. Next. At the left of the screen, there are some qualifications made by the users on Donde, sharing their experiences. And on the right of the screen, you can see the interaction between the different means to reach the users. On January 24th, we made a post on Facebook about the implant, the subcutaneous implant, and it includes the link to Donde. The same day, we received on Donde email a consultation on how to obtain the implant. So the people is being reached through social media and route to the platform, and the different platforms are interactive. Next. Related to advocacy, we see different opportunities to advocate. The one we were working most is on requests to access to public information. We made 11 requests to build our dataset, and it was very challenging because of delays in the answers, the format, and the quality of the data. And in Buenos Aires City, we work in the framework of Open Government Partnership, OGP, and the work to obtain the database, update it, and report what we received through evaluations are part of a subnational target. The next. Challenges have been almost the same since the beginning. and are related to obtain and curate databases to have accurate and complete data. But we see a window of opportunity, the impulse given by the governments to open data in the framework of OGP. On the other hand, usability and administration implies to think continuously on new features that can improve how the users browse the site and how we administrate the back end. As Donde was originally designed to locate services, the future of evaluate services was added to the original structure. And with the use, we identify some issues on the circuit the users have to do to get to the qualification survey. So we are working now on new features that improve the assessment survey. And I talked before about the possibility to advocate to obtain databases, and the other opportunity in advocacy is to work with the services and governmental areas with the evidence obtained through users' qualification. But we need to have more evaluations to design advocacy strategies based on that. Finally, it's challenging to design a digital solution taking into consideration the expectations and experiences of the different people we are working with and their agendas and schedules, especially with the public sector. But we think that collaboration is the key, so we will continue facing that challenge in order to include different views and continue improving the platform to help to close the gap between the services and the users. Next. So thank you. We wait for the Q&A moment, and there you have our email addresses to maintain in contact.
So thank you, Batiana and Mariana. I think it's the second or the third time even that I see the presentation, but I'm always very thrilled to see how interesting your product is. So if anybody has a question, you can post them. You can send them to the message or raise your hand. And then in the weight of that, I have a first question myself. So it's really great that the internet and smartphone offers us a new way of approaching young people. But I always have this question in the back of my head that if there are 8 or 9 people out of 10 using a smartphone, that also means that 2 out of 10 is not. So how can we make sure that those people those 2 out of 10 who are probably the people with the least means and the very poor young people, how that they also receive information where they can access these services, because we have the risk of kind of losing them? Or so is there, like, for example, do you also have had in mind a way of having like an offline application, or might there be a way that you can translate Donde from an online platform to like an offline application, or like a city map? Or yeah, thank you. That was just a wondering that I had.
Yes, it's also for us wondering, but we think that Donde it's useful for some people, but it complements other initiatives we have in our organization. In our case, we are a big organization, and we have several initiatives and strategies to work with the people in general and young people especially. So it's Donde appears as a solution for some sector, but we know the limitations of it. And we aim to reach young people directly, but also to the healthcare providers, because they can use Donde as a resource map, continually updated. So when they have a consultation, they also can use Donde to identify other services near or that offer other supplies that they don't have. And in the same way, currently we are developing a platform for transgender people. But we have the same question because the transgender people itself don't use the cell phones to look for information. So we think that we are going to work better with the providers than with the final beneficiary. But we think that this kind of proposals helps on some sense, but we don't have to think that there are magical solutions for all the problems we face.
Okay, thank you.
David, let me add just something. That is a challenge. It's always a challenge how to reach users, not only young people coming from a low resource setting, and there's, like Betiana mentioned, there's some different ways to complement that. People have more and more access to telephones, so having a web app that doesn't need to be downloaded, it's a good thing. Some others prefer like graphics, paper, leaflets that are being distributed. That is more like the usual way that health services are being announced and information gets to people. But also the way that this initiative has partnered with open government means that the kids that go to school and have access to a laptop that is being provided by the government also have access to this kind of information. And so, you know, it's like Betiana said, it's not the whole picture, but it's different ways of reaching different groups, you know.
Yes, I understand, of course, so thank you. So I have one question from Diana Sierra. She would like to know what is the approximately cost of building an app platform like this? Was it a very big investment, or is it difficult to maintain and to update, etc.?
It's a challenge to obtain new funds to develop the new features. I'm going to look for a budget and I answer in a minute to give a overall number.
Yeah, but just to give you an example, the resources needed for this phase that came out of this project, most of them were devoted to the platform, and because, you know, to have a responsive platform that could work on a tablet, smartphone, or a computer, that cost a lot of money, and to translate the information that we obtain from the Ministry of Health into a platform, so you can click in a place and will give you the exact location, hopefully time and days that they provide the services and the quality of services. It's a very, on the one hand, it's a very nice and friendly platform. At the same time, it's very costly.
Okay, thank you. And then one final question is, do you have a way of capture data on the sex and the age of the users that access Donde? So, like profile on what part of young people access Donde, how they use it, etc. So are it very, for example, are it very early adolescents that mainly use Donde, or are it more people in their 20 years?
The statistics of the platform show that it's not the the youngest ones that most access the platform. It's around their 20s, which is also a challenge because, you know, we are trying to reach the younger ones. So if they don't want to get pregnant, for example, they have access to good information and to services for them. But the statistics show that most people are around their 20s when they access Donde.
Okay, thank you. So I see we are over the hour. I know that some of you might still have questions, but yeah, we will make sure that your questions get answered after the webinar. We will get you in touch with the presenters if you have like any additional questions. So thank you for joining. We really we were really happy that we were able to share results of these 4 innovation projects because we were very happy with the outcomes. And as you have saw over the past 2 webinars, it were amazing project with really great results. So thank you again to Betiana, Mariana, Erin and Matthew for joining us today to present your results. Well, we hope that for everybody who attended, that this was a really great day great way to start your day and your week. So thanks again, and enjoy your day.
Thank you.
Thank you.